All right, well, good afternoon again, everyone. I will first want to thank the Dixon Center, Consensus Health, and University of Pittsburgh Center for Military Medicine and Research for their sponsorship for this great conference today. Also want to especially thank Dr. Mannion for all his leadership to help organize and put all this together, and Randall Mitchell as well. He's really helped out a lot to put all this together. So thank you all. I really appreciate it. I'm a Army veteran, 30 years service personally. I'm a physician endocrinologist. If you were on the last session, you probably heard that already. Also have expertise in clinical research and healthcare and technology specifically, and research regulatory oversight for many years. And recently, in the development of telemedicine and virtual health clinical services over the last 5 or 6 years while I was still working for the Army. I was previously the Chief Medical Officer for virtual health for the Army's Atlantic region, and previous CMIO at Eisenhower. My team and I established the first telehealth department for specialty care at Eisenhower a few years ago as well. Some of my other interests include blockchain and our artificial intelligence in healthcare. We'll be speaking with some of our panelists today about that specifically. As I mentioned, I retired from the Army last September, and currently I still do some telemedicine consultations and endocrine for the Red Cross and on some other platforms as well. And I function as an advisor for some health tech companies, including Consensus Health. With that, I'm going to go around the horn a little bit and ask each of the panelists, if you don't mind, to please introduce yourself briefly, what your background is, and the institution. I'll start with Jeremy Pamplin. Colonel Pamplin, welcome. Thank you for being here.
Thanks, Joe, and thank you to Consensus Health for inviting us to participate in this panel. So I'm Jeremy Pamplin. I'm a critical care medicine trained physician who has now a little over 19 years of service in the military, with most of my time being in trauma and critical care and burn care at the U.S. Army Institute of Surgical Research. I have had an interest in all things IT research, teaming, visualizations of data, and then telemedicine over the past roughly 10 years. And really that shift has emerged into really a telemedicine focus in a lot of ways in advanced medical technology development as I've moved over as the director for the Telemedicine and Advanced Technologies Research Center, which is a subcommand of the Medical Research and Development Command here at Fort Detrick, Maryland.
Thank you. Dr. Rutledge, good afternoon. Thank you for joining us. Glad to see you. I think you may still be on mute. Still can't hear you. Sorry. Maybe while you're working on that, I'll jump over to Colonel Junker.
No, I found it, if I may.
Okay,
sorry.
Great.
My apologies for not being connected. Thank you, Joe, for including me on the session today. I'm an internist and emergency physician, originally on faculty at Stanford and Harvard before I moved into the entrepreneurial world to use the application of technology to try and make healthcare better. I went ahead and did a PhD in computer science at Stanford with the idea of bringing technology to healthcare, with a particular focus on AI technologies in the medical computer science world. For the last 10 years, I have started and run a company called HealthTap, which has implemented and deployed a digital health platform. We've encouraged now have more than 90,000 doctors in the US working with us. They've been answering people's questions for free. There's a library of a couple of million, 3 million now, answers that doctors have given, and a platform that lets people interact one-on-one with the doctor. Interestingly, we also have an AI-driven assessment method that people can do as an automated medical interview that leads into doctor visits on the platform. And I'm happy to talk more detail about that as we go on.
Yeah, I'll ask you some more specific questions about that in a minute. Thank you. Colonel Junker, if you wouldn't mind giving us and our viewers a brief introduction to who you are and your background. Thanks for joining us.
Okay, great. Thanks for inviting me. My name is Cesar Junker. I am the director of the Human Performance Program at the Joint Artificial Intelligence Center, Department of Defense. I actually am 30 years in the service. I'm at least 10 years older than Jeremy. I look at 2, I can see he's a young looking kid. and currently am a sports medicine physician, staff at Walter Reed, faculty at Uniformed Services University, to do clinic at Walter Reed in physical medicine rehab. I also have probably over the last 10 years focused primarily my interest on traumatic brain injury and post-traumatic stress. Just a little, I mean, we'll go into it when I talk a little bit more, but the Joint Artificial Intelligence Center is, you know, under the Secretary of Defense, but it's a new organization that stood up now, I guess, over a year ago, almost a year and a half ago, under the leadership of General Jack Shanahan, Lieutenant General Jack Shanahan, and is focused on using artificial intelligence to transform the way the DoD does business. So I'll just pause there and wait for the questions and go from there. Nice to be here, and look forward to speaking to you.
Thank you. Dr. Poropatich.
Yeah, thanks, Joe. It's a pleasure to be on this panel, Joe, with you and this distinguished colleagues. I've had the pleasure of working with Jeremy Pamplin and Cesar Junker. Dr. Rutledge, look forward to getting to know you better over this next hour. I'm a retired Army doc, pulmonary critical care medicine trained, did 30 years in the Army, and spent a lot of time doing telemedicine as well. Took it to Somalia in January of '93, and then up until Iraq, Afghanistan deployments through 2012, I got out, came to the University of Pittsburgh, my alma mater, where I direct the Center for Military Medicine Research and have faculty appointment as a professor of medicine here, and I still teach and work at Uniformed Services University, where I have an adjunct faculty appointment. Again, my main interest in getting involved with the future session panel that we're in right now is, you know, I've been doing telemedicine for quite a few years now, and I really believe that the role of AI, big data, and how big data comes into play, and how you'll develop, you know, autonomous systems and predictive algorithms is going to be really important to the future evolution of healthcare. And so I want to bring that perspective into the discussion, as well as hear more from Dr. Pamplin on the great program he's rolled out on the National Emergency Telecritical Care Network, which specifically addresses the COVID topic for this session today as well. Over.
Great, thank you. Well, with that, we'll jump right in. Jeremy, I've known Jeremy a long time, since he was a resident at Eisenhower, so we go way back. So it's great to see you rise up through the ranks over the years, Jeremy, in your current position. So congratulations.
Thank you.
One of the things I wanted to ask you about specifically, Jeremy, and for our audience, is to give us a brief overview, if that's possible, of some of the innovative focus areas at TATRIC, the Army's Telehealth and Technology Research Center, but then more specifically a deep dive into what you're doing with the National Emergency Telecritical Care Network.
Wow, that's a tall order right now. Certainly to do that briefly is a bit of a challenge, but I wanted to just start. I listened to the last session a bit and was really appreciative of the experience that was on that panel, and listening to it, it made me realize, the work that has been done by really many of the giants in the field that were just on the panel, and many others over the last, 20 years or more in some cases, have really set us up for the place we are today. And the place we are today, the ability to transition and to be able to use the technology in a pandemic, is not necessarily the easiest thing to do. And we wouldn't be able to do it if it hadn't been for the work of many, many great people on the panel that came before. This is the futures panel, so thinking about how we transition the work that has been done in the past, which set us up for being able to rapidly deploy technology in the midst of a disaster. There's still much work to be done. TATRIC is the Telemedicine Advanced Technologies Research Center. Its mission is to fuse data, humans, and machines into solutions that optimize warfighter performance and casualty care. Obviously, we are not the sole owners of that mission. There are pieces and parts that go across many other laboratories and many other institutions. But the concept of fusing all three of those components together into a system that actually functions in a way that is useful is really at the heart of what TATRIC is doing now and is at the what we need to be doing over the next 5, 10, hopefully 20 years and beyond. Tatric has 4 core portfolios, and then really in many ways a kind of tech watch function or investigator-initiated research type portfolio. Those 4 core functions are the Medical Robotics and Autonomous Systems Innovation Center, the Digital Health Innovation Center, our Medical Modeling, Simulation, Information, and Visualizations Innovation Center, or MISIVs for short, and then our Biotechnology and High Performance Computing Application Institute, or BHSAI. Those 4 core functions really are getting after all the different components of what we imagine as being, first, a digital health ecosystem where all medical technologies are interoperable and work together in order to provide the data that the AI and ML will be able to interpret to help humans make better decisions. And those humans range from the novice provider to the experienced surgeon and everything in between, even the lay public. If you're unable to make good medical decisions, we imagine having the ability to have machines help us within the context of care that we are engaged in to make the best possible decisions to improve a casualty's outcome. The robotics piece would obviously fit into that, and the robotics piece is really the action arm. If you think about how medicine is employed, clinicians have to assess a patient within the care environment that they are in. They have to then make a decision about what to do. They have to treat that individual or apply an action. Sometimes that's a procedure, sometimes that's a medication, sometimes it's just holding someone's hand because that's all you have available to you. And then you have to do those 3 pieces within the context of the system. So you have to synchronize that care across the system, and then ultimately you have to take into account the resources that are available and figure out how to deliver those resources to the point of need when needed. So that's the medical robotics and autonomous system portfolio is really about the action arm, the treatment component. The digital health innovation system is really about the bringing it all together and making medical decisions or being able to assess the patient. Of course, the first autonomous system is telemedicine. You offload the decision-making capability to someone else who is not local. You give them information, they make a decision, then you perform the action. One part of the ODM loop. The BHSAI Institute is interpreting all of the data and helping us to form the clinical decision support tools. Our MISIVs, our medical modeling and simulation environment, has 2 main functions, which is first to study how we deliver services or deliver care in resource limited or austere and operational military medical environments, and then to study the base care without any support, what happens to that care when you add different technologies to it. Obviously, from the same simulation environment, you're able to collect data that would help inform additional algorithms. And then finally, the last component or last core lab of Tatric, or last function of Tatric, is our Tech Watch platform. Tech Watch space is what we call the Advanced Medical Technologies Initiative, or AMTI. It was previously run almost entirely by the Army service, but now has been broadened to the DHA level with investments from all 3 services, which is exciting. And that portfolio is really designed to ask the kind of trench clinicians, wherever they may be, whether they're MTF or an operational unit, for innovative ideas that utilize technologies to improve either the delivery of care, the access to care, or the quality of care in a way that we can study that, understand what benefit it has, and then if we deploy that or expand it to an enterprise-wide solution. So those are kind of the 4 pieces of Tatric. All those were focused a little bit on combat casualty care. I just kind of mentioned. We think about them all working together as a human-machine team to improve combat casualty care. The human performance piece is really about knowing what the casualties or what the warfighter status is at all times, from the point of being optimal, ready to fight, to just being ready to fight, so a kind of a normal status, to being degraded but still in the fight. You can think about being sick or injured but still being able to perform duty. And then finally, the transition to casualty, where the warfighter is taken out of the fight. And that casualty section, you have a lot of triage and understanding whether you can return them to the fight rapidly or whether you need to send them home. All those parts, come together again with the focus of humans, machines, and data in order to provide those solutions over time. So maybe I'll pause there, and I'm sure the Netson component's going to come up as we move forward, but I want to be sensitive to time. Over.
Yeah, the other thing I forgot to mention early on is that anybody on the panelists, if you want to jump in and ask questions, it's just not me asking questions, feel free to. Does anyone have any questions for Jeremy about some of the TATRIC core missions before we move on to the Netson project specifically? Okay, all right, Jeremy.
All right. Well, I suppose really I should couch Netson. In many ways, the folks that are involved in that project see it as an expansion of all of the good work that's being done that was discussed in the previous panel. It's the ability to deliver the right care to the right place at any time. So the Netson is a part of a larger portfolio, which we call technology and disaster environments, which you may not be surprised is aligned very similarly to the way that we think of the TATRIC core missions. And that technologies and disaster environments uses the National Emergency Telecritical Care Network as the first digital health ecosystem focused on critical care, but can obviously use the same types of technologies for other subspecialty care. And I'll tell you what the Netson technologies is going to do in just a moment. We have a line of effort that is also called virtualized hospitals, and what we initially termed as AI, or artificial intelligence infused leader dashboards, which is really about all things data. The virtualized hospitals is really about taking that base functionality, which is in the Netson line of effort, and scaling capability around it such that you can do different types of advanced medical support wherever it is needed. And you would imagine that robotics and automation, remote control are very much components of that line of effort. And then the AI-infused leader dashboard is taking data from the first two components, which is Netson and the virtualized hospitals, and making sense of it so that you can use clinical decision support and use the same data, real-time data, to provide situational awareness to leaders at all levels. So what is Netson? Because that's really the part that is most immediately available. Netson is a kind of lightweight or low tech. It's not really low tech, but it's not adding a whole lot of hardware solution that allows you to deliver medical support or expertise to the point of need. Again, we imagine that being related to critical care expertise in the context of severe COVID-19 illness, and the minimum functionality of the Netson product is really structured around the network-enabled mobile device. In this delivery system, we imagine that all endpoints have access to one of these, a little phone that allows you to communicate, send asynchronous information, collect information from the environment, and communicate across space and potentially time, again with the asynchronous components. And in that context, a mobile device requires network. So we know that in disaster settings, even if network goes down, the typical cellular network or your Wi-Fi network in the hospital, it's relatively easy to reestablish network with various different mobile devices, drones, satellite, etc. So it's a very ubiquitous solution. And the fact that most of us have mobile devices, or that mobile devices are relatively easy to deploy, easy to stockpile, relatively cheap, you can essentially rapidly deploy mobile devices, either because you have your own or because the system needs to deliver you that mobile device to help you with your care. So again, telemedicine services. First use cases focused on telecritical care, focused around the technology that is within the mobile device, and the network connection that is delivered to that mobile device from primarily cellular-based systems. But again, if you have more robust networking, you can use that. That's the base functionality, and we are looking forward to working. We have 6 teams. I don't know if you want to get into those different teams now or later, but those 6 teams have completed 2 rapid sprints over the past month and a half in order to deliver what we consider this minimum viable product that we can hopefully deploy to real-world settings in the very near future.
Thank you, Jeremy. Yeah, maybe we can get more specific, some questions about the details a little bit later on. I appreciate the great description of the TATRIC mission, and Edson, thank you. I'd next like to move on to Dr. Rutledge. As Dr. Rutledge mentioned, he's one of the co-founders and chief medical officer at HealthTap. Dr. Rutledge, I'd like to ask you to share with the group and the audience a little bit about the development and use of AI on the HealthTap network.
Well, thanks, Joe. As you mentioned, it's been a journey for us. We started the company about 10 years ago with this idea that it ought to be possible to get your healthcare on your mobile device. There's a bit, I think we were kind of ahead of the game, if you will, in getting started, and it's been quite an interesting journey getting doctors to participate with us and mobilize their assistants to help as we built the platform. In its current state, the platform really does 3 different things to support the delivery of what we think of as more efficient, more effective, and higher quality healthcare. The first step is people have a question or a concern related to their health, and they'd like to get a trusted answer, one that they can believe. What we've done is we've let people ask questions and let doctors answer them, and then have the doctors do peer review. That part of the site is done at scale, and it's free. So you don't have to pay to ask a question, and we don't pay the doctors to give answers either, but that gives the orientation around information. The next step really is where the AI comes in, which is the ability to say, well, hang on, I may have an informational question, but now I have a problem I want to get taken care of. I have a concern, I have a set of symptoms, and I'm wondering, do I need to worry about it? Or if I'm curious to understand what might be the possible explanations for this, and this is how AI is currently deployed on the HealthTap platform. So you start with a symptom and then engage in a medical interview, which is automated, fully automated interview where you can assert or describe all of your symptoms. When you name a symptom that's important, we will follow it up with a series of questions to refine our understanding. You know, what's the quality, what's the duration, what are the things that make it better and worse, and so on. And then after you describe the various symptoms, we consult our knowledge base. Currently, the current system is implemented as actually a knowledge-driven system rather than an AI ML system. And with that approach right now, what we can do is we say, oh, for that set of symptoms, let me look at the possible explanations, what conditions might explain the symptom complex you've just told me you have. And then we look for the other symptoms we don't know about that, if present, would distinguish among the different alternatives as possible explanations. And so it's like exactly what you do in the office when someone tells you I have they describe your problem, and you ask about questions that reveal whether it's one or another possible explanation for that problem. So that currently the net result of an interaction with the person is that the AI can create a set of possible explanations, up to 10 actually, different conditions that might explain. Now, interestingly, when people use our platform, they put information in it regarding age and gender and location. They might put in their medications, allergy history, prior medical conditions, and so on. So all that data is actually also incorporated in that initial evaluation. We don't have to ask the questions again if you're using the platform. So that AI-driven condition list gives a person who is undergoing or has done the interview an idea of the possible explanation. And for each condition, of course, you understand the severity or importance or the need to connect with the doctor. What we enable is after you've done that, you can push a button and literally we send the entire transcript to the doctor, who is immediately available. The average, we staff in the US anyway, across every state, we staff a doctor all the time. So our median time to the doctor's face appearing on the phone after you press the button, I want to talk to the doctor, is currently 26 seconds. So doctors are immediately available for interacting. When the doctor says hi, well, the first thing they get to see is all the symptoms you said you have, and even more important, all the symptoms you said you didn't have, because when the answer is no to the questions that were engaged, the pertinent negatives appear also. So the doctor's given a leg up, if you will, and they can very quickly use as a starting point the result of that automated medical interview, which makes the interaction more efficient for the doctor. The other really thing that I'm very proud of and that I think is really intriguing is that in addition, we show the doctor the results of what the AI said might be the explanation for the patient's initial symptoms. And interestingly, I was able to show, I studied this in a separate project, that when you show doctors a list of possible explanations, their ability to recognize a standardized scenario goes up significantly. It's not a small amount. It went from 55 to 80% of the time doctors getting the right answer when they're given a list of alternatives compared to just looking at a scenario and trying to decide what might be. So I'm very thrilled with this idea that the technology, the AI, can support the doctor's decision-making at the point of care when you use intelligence to look at what's going on and suggest possible things to think about. The AI doesn't have to get it right each time. The doctor is ultimately responsible for understanding what's going on, making diagnoses and confirming what the patient actually has, and we trust the doctor to do the right thing, but we see the AI as being a supporting tool that makes the doctor's interaction more efficient because it can take over and do the routine parts of the medical interview, and then also supporting the doctor's clinical decision-making by reminding the doctor of the things to think about for the doctor to recognize in the scenario they see for the patient. And of course, the platform also allows the doctor to write prescriptions and order lab tests and arrange follow-up and so on. And that's live today. We're actually, and the last thing I want to comment on, since that's sort of one of the focuses for the session today, is what happened with the pandemic and how does AI get configured, or how can we leverage the AI for pandemic concerns? And fundamentally, what we were able to do was create a new profile for COVID-19 and include that in the current system because of the knowledge-driven basis of the system, putting in the knowledge of what COVID-19 is, how it manifests, what the symptoms are, what the risk factors are, allowed us to quite rapidly add COVID-19. So if you put in symptoms of flu-like illness and you're living in a COVID-19 endemic area where you describe that you've had exposure to someone with COVID-19, then COVID-19 becomes a likely explanation for your condition, and that's in the system. And of course, also at the point of care, when you're interacting with the person, you have not only the video, but a chat stream. And we're able to put into that by creating virtual practice guidelines for the doctors. We're able to put in front of the doctor an update on a continuous basis what guideline for managing patients that may have COVID-19 is most appropriate. So having the platform, the digital health platform, gives a distribution method for the latest guidelines for how to actually manage care, and that's happened. This is all live on the product now. The other thing about the pandemic was the realization that a lot of people had lost their jobs, and with it many times lost their health insurance, particularly if they couldn't afford the COBRA payments if they had it before at all. And so to address and to help the people that are actually without health care, we decided not to require an annual payment for the service and make it available for just $10 a month. So today anyone can go to get access to a doctor on HealthTap with just an initial $10 payment to get started. And that really was a direct response to the need in the marketplace. And I'm happy to take any questions people may have about how that works or what's up with it.
Thank you, Geoff. I guess we'll move on around the panel and then maybe come back for questions towards the end for the sake of time. Thanks again. Dr. Poropatich, can you tell us a little bit about your project that you're currently working on in trauma care in a rucksack and how that might get into civilian care?
Yeah, thanks much, Joe. And it really follows, from what Dr. Pamplin commented on. The project that I'm going to describe, trauma care in a rucksack or tracer, the problem we're trying to solve is how do you treat someone far forward on the battlefield with an autonomous system using robotic intervention to provide life-saving interventions. And imagine again a small form factor, a backpack on a drone, man or woman down the battlefield. It's safe to land the drone. Buddy A takes out the backpack, applies a sensorized body wrap to that casualty. It interrogates the casualty. In that cloud computing that's talking to this computer in the backpack, it lets you know what the baseline health of that casualty was before they got injured, or the casualty's wearing some kind of active device that give you the baseline right before injury. The point is that it then interrogates knowing what baseline looked like, what they look like now, there's a delta there, and then through clinical decision support, you drive through some kind of rational decisions of what to do to this casualty. The robots were intended to do a tracheostomy, needle thoracostomy for pneumothoraces, and then cannulate the femoral artery and run a balloon catheter up the aorta to the liver spleen takeoff, put a balloon up and provide occlusion for non-compressible torso hemorrhage. That is a lot of stuff that's going on. It represents team science between University of Pittsburgh and Carnegie Mellon. We're very grateful to Dr. Pamplin and his team out of the medical robotics and autonomous systems portfolio that Jeremy commented on is where this project is being funded. Again, multidisciplinary, multi-organization. The secret sauce is all this pre-hospital data that we generate. And again, this gets into what Dr. Junker is going to talk about, what Geoff has already commented on as Jeremy, in terms of big data. We do 13,000 medevacs a year for the last 20 years. We have 250,000 plus patients in there. Really rich data. It's granular. It's got the audio of the guy on the chopper talking to base station, the video of intubations. It's got the monitoring, the actual waveform data. We take those 250,000 patients. We identify the 18 to 55-year-old representing a military population. We pull out those that have penetrating or gun trauma. And then what we do is of those, what we have right now is around 26,000 patients that we then map that outpatient pre-hospital record to their inpatient record and overlay that with machine learning to come up with a predictive algorithm. Then we're going to take a bunch of pigs, traumatize them, bleed them out, give them pulmonary contusion, overlay them with various FDA-approved devices we use in the ICU, and see which one of those biosensors, those biosignals are going to be more predictive for decompensation. That'll give us a better clue to what's going on with the casualty than heart rate, blood pressure, pulse ox. Those of you that take care of sick people know that by the time heart rate, blood pressure, pulse ox decompensates, it's too late. So we're looking at pulse pressure variation, stroke volume variation, mixed venous O2, really important sensors. We just did a pig experiment yesterday, and it was really exciting to see this functional hemodynamic monitoring capability kicking in as we bled out the pig, as we gave pulmonary contusion. We're giving norepi, fluids, blood, and it's all being done through the machine, sensing the casualty and then treating the casualty. We're then going to take that algorithm, refine it, put it in normal humans, put them in a box, suck out all the air, lower body negative pressure, and then simulate hemorrhage in a normal volunteer to see how well and iteratively develop the algorithms. Then we're going to put it in our ER. Then we're going to put it in the back of a chopper and see how well it works. So it's a very ambitious project. It's got some really strong performers here at the university. It's very deep in talent with computer scientists and clinicians and trauma surgeons, emergency medicine. But the key of it is the pre-hospital data set and big data. Again, we truly believe that everything we're doing for the military looking at trauma, we're also funded NIH with 3 R01s looking at non-trauma, so heart attacks, GI bleed, COPD exacerbations. We're looking at the same pre-hospital population with trauma, with DoD funding, non-trauma with NIH, trying to come up with ways that we can better assess the casualty and then tell whoever's there how to treat them. The civilian applications, imagine the nursing home patient population, dad doesn't look quite right, but it's not enough to send them to the ER, right? Well, if we knew dad's baseline health, then maybe we can query dad's baseline health and what he looks like on a good day, and now he doesn't look quite right, I'm not sure what's going on. Through some of these sensors that we hope to develop over time into a form factor that would work in a nursing home, we could then tell you early on that, well, dad's actually sicker than you think, and you need to intervene with fluids or antibiotics, et cetera, and avoid that costly ER ICU admission. So a lot of MilSiv applications, a lot of team science, and we're grateful for the opportunity to do all this and see how it would play in remote settings, that kind of clinical decision support capability. So that's the innovation, that's the key challenge. We're 1 year into this 4-year funded effort, and we'll continue to march and hopefully meet the critical milestones over time. Thank you.
Great, very interesting and intriguing project, Dr. Poropatich. Thank you for sharing. I look forward to hearing some of the questions that we'll be getting soon. Colonel Junker, thank you again for joining us. Would like to hear next from you, and you mentioned the AI that you're working on, the center, the newly developed center. Can you tell us a little bit about what the role is and what some of the projects that you're currently working on in the area of AI?
Sure, thank you. I just was listening to Ron talk, and wow, that was a quite impressive project that he's doing. I mean, in my mind, I'm like, that's science fiction. Ambitious, to say the least, Ron. That's quite impressive. So yeah, how far you go. And congrats on that. Well, a little something first about my specific portfolio, which is human performance, and under that comes suicide prevention. So obviously we know that suicide is a really big problem, both in the civilian sector and the DoD. It's our #2 killer in the DoD right now. And deaths continue to increase, and a solution has been elusive for quite some time. So despite our best efforts and lots of money and lots of manpower going into trying to prevent suicides, we continue to have the rate go up. Last year, 2019, was the worst on record. So just to start a little bit about what we're doing specifically. So when someone commits suicide in the civilian sector, usually they do a death report, and they're trying to rule out nefarious causes. Can be a paragraph, could be a couple pages. It's variable. State, county, cities all have different regulations on what is required. In the military, on the other hand, you have comprehensive investigative reports by the commensurate service-specific organization that does that. So Office of Special Investigation, OSI, in the Air Force, CID, and in each case, they're not just doing a kind of short report, they're doing a report that looks at motivation. And so because it's so comprehensive and so full of data, we felt that we would be able to find a signal for exactly what is most critical in someone that commits suicide, that's successful at committing suicide. And we're in phase 1, which is basically labeling the data and doing taxonomy. Specifically, we have 500 OSI reports, so those are the Air Force investigation reports that go into great detail, photographs, social media streams, all just so data rich. Never been done before. I think you may or may not be familiar with the Army STARS program. They're 10 years now. Hundreds of millions of dollars spent there over the last 10 years and their next 5 years to come. And they've done some similar things, but they've never been able to do ML or apply AI to the actual data, because they weren't able to do the natural language processing, natural language understanding that we're attempting to do as we speak. So phase 1 is labeling the data. The next one is to create an algorithm, and then a user interface, and then phase 4 would be have that user interface transition to our partner. So who are our customers? We have 3 customers. Our first customer is the Insider Threat Program. Second one is commanders. So all 3 services, the commanders we're commanding is Commanders Mitigation Risk Dashboard. And then finally, the DHA. So it would be an algorithm would sit, predictive algorithm would sit on the EHR platform to give providers an indication of someone that was at an increased risk. A little something about insider threat. So every service is required to have an insider threat program. It exists as we speak. That's Big Brother looking at everything you're doing. Anyone who's part of the Department of Defense or has a secret security clearance is being monitored and signed away their life. So they're looking at every data stream that is available. And it's quite impressive what data streams are available right now. So the way that I look at it, oftentimes people say, you know, it's all about security and giving up your rights, et cetera, et cetera. I'm like, all we're going to do is make things better because it's happening right now. Right now, they are doing it, and they have either no algorithm or imperfect algorithms. So we're just trying to make things better. But they are intervening. They're making interventions on the data that they get, and you know, oftentimes these things can have consequence on people's careers. The Army, well, the next set of customers, the Commander's Mitigation Risk Task Force, each one of the services has a program. They're right at the Chief of Staff level of each one of the services. People are really concerned about this and really want to see it be used wisely, and are excited about the potential in using these algorithms. Army is probably the most mature, and I will tell you, Jeremy is the only active duty Army person. You know, it's truly scary what data is available and what they're doing with it right now. So hopefully we'll be able to help them and go from there. And then the third one is DHA. Obviously, this would just be a predictive algorithm. Now, before I kind of like just summarize what we're doing, you know, I listened to what a lot of the people just that were speaking, talking about big data. And, you know, what I would tell you is that I've been in this project, just suicide prevention, for, you know, close to a year now. And without a doubt, you know, access to data, this is really personal data, and putting it in an environment that is able to run these algorithms and use AI. In this case, we're using we have Microsoft, Johns Hopkins, and APL, Applied Physics Lab, all participating in this project with us. Well, we're paying them, but you know, put it in an environment where you're able to successfully use it and meet all the requirements to keep data secure is you know, a monumental effort. And so, you know, we're not like a research. We don't do research at the Jake. We're actually about execution and projects that should be executed within 1 year. And you know, that would be a question that I throw out to the group from someone that's actually out there in the trenches doing the AI and trying to actually come up with a product that I'm responsible to do. It's unbelievable, like how difficult it has been. Even though there's 5 years of work before me, you know, Army Analytics Group and all the data streams that they have, and everybody's trying to do this, yet it's extremely difficult when it comes to execution. And I think that's ultimately where we are right now. I always feel like the smartphone analogy is really good. You know, there was the original smartphones that came out before I don't know if you remember the Trio, where it was like it had a QWERTY keyboard. And actually I had one. I remember it was very useful. It was like the first one that I think came available that were smartphone technology. But what we didn't have was data. I mean, not data. We didn't have internet connectivity, right? And so that made it, you know, cumbersome. And any app or anything that they were trying to do was, you know, it ended up being unsuccessful because it just wasn't ready. And now look at us. You know, look how important the smartphone is. And you know, there were so many people that had the right technology, the right ideas, but they were too early. And I don't know. I especially to Dr. Rutledge and Dr. Pamplin, maybe into Dr. Poropatich, you know, like that'd be a question that I'd like to throw out to you guys. It's like, do you think we're just too early when we're trying to apply the AI? Especially, it's a very complicated. You know, I'm not an AI scientist, but I'm becoming one, and learning how complicated it is to actually make it available and produce a product. it's cumbersome, to say the least, and lots of hurdles to overcome. So anyway, I throw a lot of question to the group.
I'd like to comment on, I couldn't agree more that it is a challenge to do it right. Also recognize the sheer volume of data that are needed to do it well. When you have if you have a single binary decision, it's a lot easier. Does this chest x-ray have signs of pneumonia or cancer, or is this breast cancer or not? Those kinds of systems can be built in a very focused way with relatively smaller amounts of data. When you have a general purpose approach to trying to understand, in my case, for the Dr. AI, for example, the symptom assessment, allowing anyone with any symptom to present and being able to give a reasonable result similar to what a general practice doctor, a primary care doctor would do, is really quite an undertaking. I described that we built the first version of the system as a knowledge-driven system. It's a Bayesian inferencing engine that can be built using expertise and expert knowledge, and I got the doctors, I trained the doctors in the network to support this, and we had 250,000 inputs from doctors in the network giving us guidance to our knowledge. But even at that, the structure of a knowledge-driven system is limited by the assumptions you have to make. Fundamentally, conditional independence of the symptoms is a limiting factor for how good it can get. It works, but if we want to make it better, we believe the only way to do that is to have a purely data-driven ML approach. And to your point, getting the data and getting it organized is not a small undertaking. We've actually partnered with the healthcare system and have access to 20 million patient years of ambulatory health records. And we're actually in the midst right now of extracting from that set of data all of the relevant features, because we're doing clinical diagnosis. This is not numeric measurements from a smartwatch. This is the patients told the doctor they had a cough and chest pain and fever and short of breath and abdominal pain and whatnot. And so we're actually running the unstructured clinical notes from those encounters through an NLP pipeline and creating a common data model and a clinical model for each case from each of those encounters over the last 10 years. 2 million patients a year for 10 years is what the data set comprises, and using that as a training set to build a better clinical prediction model to drive this, with the idea that based on what actually happens in the real world, it should be possible to improve the performance. But I'll mention parenthetically that that's great, but now when COVID comes along, you don't have 20 years of data on COVID in the first month. And what's needed is a flexible system that allows you to combine knowledge-driven inputs with the observational inputs from the past. In a true Bayesian sense, you start with the prior and then you update it with new information. The analysis of the data from large amounts of clinical data deriving a machine learning method still needs to have the ability to provide expert-driven guidance to improve its performance, I believe. I'm very excited by this idea of being able to create lead even better clinical prediction engine than is possible to do with a purely knowledge-driven approach.
So just a quick question. So you think we're pre-trio, trio, or just after the trio?
Well, the early iPhone worked and really showed what was possible. In the end, it didn't. Well, but the early iPhones did not deliver what we have today. The early iPhones showed what was possible, and they were exciting, and you were enthused to use it because you could see what it could do. And the limitations were real, and they were limitations that were going to be uncovered or fixed sequentially in new iterations. So I think that's where my take is. That's where we are in the stake now. We can see it. It's real. It's possible. And we can make it work, but we need to improve it to make it really effective and functional and incorporated as part of a routine workflow.
I think one of the other really important pieces we should at least acknowledge is I think Cesar's point of where we are at in terms of timeline, and Dr. Rutledge's point about where we are at in terms of imagining the future. There's also the challenges related to how we navigate that path towards the future with respect to creating systems that don't cause harm, and certainly systems that can be trusted. And one of the challenges I would imagine, and I don't know how the diagnostic accuracy or the diagnostic choices are presented to the clinician in your particular system, but there's the whole concept of automation bias or AI bias, right? That can actually cause the human to make the wrong choice sometimes. And one of the challenges to Cesar's point is that we have precious little data when it comes to both hospital-based systems and to Ron's point, pre-hospital-based systems, particularly for the military, right? I mean, having data in the pre-hospital military settings is just, particularly for combat casualty care, is very hard to come by, especially data that can be used for AI or machine learning. So the data component is exceedingly important. The way that it is annotated and curated such that it can be used to create better knowledge engines, and then ultimately the ability for us to trust it is are kind of three different components that I think really need to start growing over the next several years for us to really take advantage of this wave of AI enthusiasm, the new iPhone, over the next several years.
Yeah, I could add to that.
If I could just follow up to Jeremy's point, one of the challenges we've had, collecting all this pre-hospital data and in-hospital data and having, hours and hours and days of monitoring data is making sure that it's good data. And so the whole issue of artifact detection has resulted in its own AI developed sub-project within our bigger project. And so when we look at the pre-hospital or inpatient, in the ICU data, for example, just being able to parse out good data from bad data, to Jeremy's point, then curating it has been a major challenge, sidelined us for a while. And until we could determine that AI developed artifact detection system and really get it working well, then once we did get it working well, we really, logarithmically scaled up in going through the data analysis. But it took some time to be assured that what we were doing AI machine learning on was good data to begin with. So it's a big issue and one that continues to be a challenge for us.
Ron, I
think we should probably just comment on the fact, that this challenge, one of the reasons this challenge exists is because of the way that we are collecting the data, right? And as we evolve the technology, so one of the reasons we can have some of these conversations because the current iPhone or the current Android device is not the Trio, right? So the technology has evolved, and we have to put into place some of the new technologies that allow us to do some of the things that Ron is talking about, which is the curation and error detection automatically. And the way you do that is with just the way that the clinician does, right? The clinician can look at the monitor and see a flat line on the EKG and not bat an eye because the other waveforms on the monitor are doing just fine, right? And the machine though is sitting there beeping like the person's dead. In our current day, in our current age. So, how do we actually allow the devices in the medical environment to become more interoperable and understand what the status is of the other devices, essentially creating the medical Internet of Things that allows us to do the AI in such a way that it actually makes similar observations that the human does. The challenge behind some of the tracer data looking at the pre-hospital system is it's still limited in the number of sensors that are available, and it's still limited with the artifact of those sensors. But there are other sensors that are out there that could help the machine understand why there is artifact at a specific time or what the ground truth is related to the scenario that's going on. It's probably not a single sensor, right? It's probably multiple sensors that help to define what ground truth actually is. So again, this is the journey we're currently on of adding more data to the system.
Somehow the use of a single sensor causing airplanes to crash comes to mind as a reason not to rely on any single channel for such information. Ron, I don't know if you saw the paper preprint that was published this month from Fitbit, where to your point about sensors, biometric sensors, they were able, did you see it, Jeremy? They were able to show that just using the data that came off a smart health watch, or one that recorded pulse rate, heart beat-to-beat variability, and respiratory rate and skin temperature. They're able to show that in a stream of data for people that were subsequently found to be positive for COVID, that they could detect the presence of COVID about a day before the person became symptomatic and was aware that they had a problem and sought attention. This idea that large amounts of data collected across big populations can be input sets to machine learning methods to identify patterns that would be much more difficult to see. And it sounds related to the work you're doing in terms of having a large amount of data and then being able to predict what that data means without, in an automated fashion.
Yeah, and that's ironic that, like in the January, February timeframe, there was a New York Times article talking about how wearable devices and patient-generated data will be so helpful in predicting flu and identifying earlier flu. And then sure enough, here we have the panic with COVID-19 doing essentially the thing you just talked about, Geoff. So appreciate that information.
I think we really need a paradigm shift though, right? Both of the articles that we're talking about right now still continue to focus on human physiology, right? As some magical marker of disease state. And I can guarantee you that my mom used to know when I was sick without ever taking my heart rate, because she would see that I stopped doing the normal activities of a little 5-year-old kid running around and jumping off of whatever I was jumping off of at the time, right? So, again, adding in some of these other traditionally non-medical sensors, and I guess the question we have then is, why don't we do that, right? And the answer still is for right now the FDA. But as we evolve and into the AI space with some of the innovative folks that are certainly on this call, the PIT team and many others, looking at the non-medical sensors, right? Looking at the Internet of Things that actually define your activities and your behaviors in a way that is not just related to physiology, I think is the direction that we're going to be going, certainly for the soldier, but also for identifying just the overall health of humans and figuring out how to nudge them in the direction that's going to be most appropriate to keep them healthy.
It's a good point. If you think about physicians, one of the things we look at is the impact that the condition had on the patient's behavior. We ask specific questions around, how are you sleeping, and did you change your activities? To what are you not doing as a result of not feeling well? And that's an important driving force for assessing how serious or significant the issue is. There's no reason not to get that data.
Very high signal, but they're not captured in any of our AI algorithms right now. Like in the hospital, they're not captured in the ER as a piece that really drives a machine's decision-making process. We are still very focused on some of these other easier to collect but potentially less meaningful data sources.
Yeah, I couldn't agree more. There's so much data on this device that'll tell you if I feel bad or not, just by how much I'm engaging with the things I normally engage in, whether it's movement, social media, emails, text. You can get a sense of something's wrong with me if all that drops 50%, or maybe
or changes. It may not be a drop in any particular measurement. It may be really the delta between your baseline, as Ron pointed out, exactly, and your current state that really helps to define what happened. But again, these are assumptions. We need to look at the data and actually start to collect it.
Well, Joe, how about doing sentiment analysis on what you're saying when you're using the phone?
There's active research in that space as well.
Well, folks, it's been a wonderful discussion. We're almost out of time, so I thought I might read a couple of questions that came in from the audience in the last few moments that we have, if everyone's okay with that. Dr. Poropatich, there was a question about during your venous occlusion testing, have you done any biomarkers with the animal studies to help see if you might be able to have some information to predict cytokine storm that might be relative to COVID?
Yeah, we have not looked at specific biomarkers because we're trying to put together this sensorized body wrap, if you will, that is not going to be doing a lab measurement. It's primarily all just physiologic measures. And so at this point, there are no biomarkers planned in the first iteration of the project.
Thank you. And another question about biomarkers, and this is for you, Dr. Rutledge. on the Health Tap platform and the AI algorithms, are rare conditions and the symptoms of rare conditions included in that? And the follow-on is the ability to input biomarker results part of the patient input capabilities?
There's absolutely nothing preventing you from doing that, in the sense that if the information is available, it can be used either as inputs in the training set for an ML-driven model, or explicitly added in a knowledge-driven model. We did focus our system on the questions that we could ask a consumer who came to healthtap.com using consumer language and our ability to get you can't ask a question the person doesn't know an answer to. You can't ask a question so technical that a layperson wouldn't literally understand what the meaning is. But you can ask, hey, did you get a test for this? What was the result? And get inputs if the person has them. It just, in the usual use case, the person coming to a consumer health service doesn't yet know what they have. And so it's not been a tremendously helpful part. On the issue of rare conditions, we definitely included, I think it was 667 conditions in the original knowledge set. But the reality is that most, the common condition is more likely explanation for the symptoms, for rare symptoms, than is the rare symptom for the scenario. And so what we see is that the relatively less common conditions get on the list, but they're toward the bottom. And this, of course, is why I think it's valuable to put it on the list, so the doctor can be triggered to think about it. Hey, gee, could this be a case of that? And just to actively consider something that would, because it's rare, is not front of mind in thinking about cases.
Great, thank you. One more question for you, Dr. Rutledge. Someone asked, how does malpractice fit into the Health Tap if it's just $10 a month?
So malpractice is included on the non-doctor side. It's not delivering care, whether it's an answer to a question or a doctor AI session. That's informational interaction, and it's not delivery of care. And it has not been a concern at all. Overall, the history, the track record of healthcare in America is that even though there's huge concern about a new channel, and my goodness, doctors all say to me, I'm afraid of the concern. The reality is the track record of malpractice litigation on virtual health has been phenomenally good. We have a liability policy that allows us to provide care for less than $1, malpractice for less than $1 a visit on average for care. So and by the way, in 10 years of doing this business, we've not had a single threat of litigation, let alone actual malpractice case against any of the doctors in our network. It's a combination of self-selection and acuity and outcomes and continuity of care that leads to that solution. So even though it's a concern that virtually every doctor has, it ends up being a non-issue. And this is reflected in how low the insurance premiums are from Lloyd's of London for doing malpractice coverage for doctors giving virtual care.
Thank you. Well, we're just 1 minute past the hour, so I think that wraps up our session. Again, I want to thank all the panelists for participating, your willingness to be here this afternoon and sharing with the audience. Thank you so much. And again, thanks to the organizers and the sponsors. Don, I'll turn it over to you.